we can operate is because we have people on our register. And one of the main reasons we have people on our register is because we have extremely amazing volunteers like yourselves who get them on the register in the first place. So that's why it's so important for us that you're happy and you're happy to continue your amazing work. And that's why we're here to support you as much as possible as well. So as I said, my name is Ruta. I'm a medical officer for Anthony Nolan, but I also worked as a hematology registrar. That means that I've seen the recipients and I looked after the recipients of our bone marrow transplant patients, which means that I've seen what difference it can make to the people who do receive transplants. And today we also have a special guest. So Jerry O'Brien is a final year medical student at Plymouth University, and she has participated in Marrow chapter in Plymouth for 4 to 5 years, and she has a lot of experience that I think you would benefit also from hearing her experience as well. So she will do a little bit of this talk at the end of the lecture. And if you have any questions, if you want me to facilitate organizing any sessions on anything, if, for example, you have a very scientifically minded chapter and you want to learn more about transplants or what's happening with transplants, feel free to email me and we can arrange something as well. So because this is a very, very broad topic, without further ado, we're gonna start, if that's okay. So the objectives for today are we're going to cover some basic concepts and just terms that we use when we talk about transplants. We're also going to talk about the almighty stem cell, which is what we collect for our donations and what we're interested in, and why is it so important for the bone marrow of a person. And then we're going to talk about why and how do transplants work. And we're mainly going to explore this by looking at 2 different journeys which are interconnected. So the recipient's journey as well as the donor's journey. So when looking at the donor's journey, we're going to look at what is matching. What does that mean? We're going to look at the donation process itself and some possible complications that the donors might experience as part of the donation process. And then we're going to look at the recipient's journey. So we're going to look why might a recipient need a transplant, the process of how does the recipient get to the transplant process itself, and also looking at some of the complications of the transplant, namely something called graft versus host disease, but also other impact that it can have on the recipient's life. So this is there's a lot of different words on the slide, and we're just going to go one by one trying to explore them. So we have a term hematopoietic. All it means, breaking it down, it just means that it's related to blood cells and their development. That's all it is. A stem cell is a cell that which is can then become any sort of different cell. So if we put those 2 words together, a hematopoietic stem cell means that a stem cell that can develop into any type of blood cell. Okay, that's all it means. And hematopoietic stem cells are the ones that we collect from our donors and put into our recipients. Now, when we say bone marrow transplant and when we say stem cell transplant, we tend to use those words interchangeably. However, strictly speaking, bone marrow transplant means that we collected the cells directly from the bone marrow, usually from the pelvic bone. And the stem cell transplant technically means that we collecting it from the blood. So we attach someone to an apheresis machine, which looks like a dialysis machine, more or less. And we collect it from the blood instead of going directly for the bone marrow. However, these terms are used very much interchangeably, and we can, you can use whichever you want. It's not strict science. When we say someone is having allogeneic transplant, that means that we are taking cells from the donor and putting it into a different recipient. And this is the work that we do with Anthony Nolan donors. However, in medicine, we also do autologous stem cell transplants, where we collect the cells from the donor, freeze them, and then put them back into the donor themselves. So this is used a lot for lymphomas, myelomas, even diseases such as multiple sclerosis, as well as some other tumors like germ cell tumors. We don't do autologous stem cell transplants in Anthony Nolan. The whole point of having a wide register is to find an allogeneic donor. And for this, that means that we're looking at more acute diseases that we can treat with allogeneic stem cell transplants. Word engraftment just means that those stem cells that we put into our recipient from our donor took over the recipient's bone marrow and are very happy living there and produce all the blood cells that the recipient needs. Graft versus host disease. So when we collect the hematopoietic stem cells, we not only collect those stem cells, we also collect a little bit of lymphocytes, and there's some red cells there as well as a byproduct of the collection. And those lymphocytes can recognize the recipient as being foreign and can attack their body systems. Now, we have tricks how to dampen down that response, but we also want a little bit of that response, not against the recipient, but against the disease, because those cells will recognize the disease as something that is foreign as well, and hopefully will attack them, the disease, and will allow us to clear the disease fully. Okay, so these are just the basic concepts. Now, this is the cell that we're mostly interested in, which is the multipotent stem cell. This cell can end up becoming any of these cells at the bottom, be it platelets, red cells, any of the granulocytes like a neutrophil, basophil. It usually it decides whether it's going to become a myeloid cell or a lymphoid cell relatively early. But this one cell is able to become any of the blood cells. And that's why they are so precious, because when we transplant them, then they home into the bone marrow of the recipient and then can reconstitute any cell in their in their blood. And that means they will produce all those cells, and that means that the recipient's bone marrow is going to be replaced by the donor's bone marrow. So just to show how amazing those stem cells are. Now we're going to talk about the donor's journey first. So obviously, you know way more than I do about how to register the donors into the registry, because that's basically what you are doing. The bits I'm going to cover is what we're talking about when we're talking about matching. Then the donor, once the donor is matched to a recipient, they're going to undergo a medical check to make sure, firstly, that they're well enough to donate, but secondly, to make sure that there's nothing that we can transfer from the donor to the recipient that can be of an issue. So, for example, any infection, any cancer cells, or anything like that. Then after the medical, after we're happy that the donor is healthy enough to donate and it shouldn't cause any problems for them, we will talk about donation and different types of donation that the donor can undergo. And we're going to shortly talk about what's going to happen after the donation. So basically, after the donation, we follow up our donors to make sure that they're okay. We check on them on day 2 after the donation, on day 7, then monthly, and then yearly up to 10 years. So we do keep in touch with them. One of the reasons why we do keep in touch with them is that sometimes we want some extra cells from them. So as we were saying that if, for example, the donor cells decided to live very well in the recipient's bone marrow, but for some reason or another, the recipient's bone marrow cells are starting to regenerate and starting to take over the recipient's bone marrow and pushing out the recipient cells, we might need to collect a little bit extra and introduce them into the recipient so that they take over the recipient's bone marrow cells again. Okay, so we're going to talk a little bit more detail about this as well. So what does the matching mean when we say that someone is a match? Usually we use term 10 out of 10, and what it refers to is human leukocyte antigens. Now, these antigens are just sort of like little flags on top of the cell that tells our immune system that that cell is part of us, and that those cells are not foreign and that they shouldn't be attacked. So, so that's sort of a communication system between body cells and the and our immune system. When we say someone has 10 out of 10 match, what we're looking is at the specific human leukocyte antigen. So we want to make sure that the A, B, C, TRB1 and DQB1 antigens match. And we inherit a sequence of those antigens, one sequence from the mother and one sequence from the father, so that we have 5 different types of human leukocyte antigens twice, and we need all of them to match. So we need 10 out of 10 match. We sometimes do transplant people with 9 out of 10 match, which means that we will get more graft versus host disease because the cells we will be introducing will recognize the recipient as a foreign entity. However, recently, for the last about 10-15 years, we also found ways where we can match only one of these sequences, but not both of them. And the graft versus host disease is not so severe because we give them something called cyclophosphamide after we infuse the cells to dampen down those cells. And we have quite good results with that. And if you think about it, that means that we can match only 5 out of 10, and we're more likely to find a donor for people who have really rare, less common, let's say, sequences. Now, the problem with human leukocyte antigens and the genes coding for them is that there's so much variety between people. Especially we see even more variety between Black African as well as East Asian and also South American populations. They have more varied combinations of those genes. And that's why it is more difficult to find a match for them. And that's why we also want to try to expand our registry as much as possible to try to get as many as possible people from those backgrounds as well. Now, just sort of illustrate matching a little bit further, I'm going to use this diagram. To make it a little bit easier, I color-coded it. So this sequence will be red, that sequence will be green, and maternal sequence will be purple and blue. And you can see, so if these people have children, these are the possibilities of what variation in sequences in the HLA antigens they can have. So you can appreciate, even just looking at this diagram, how complex it becomes quite quickly and how difficult it can be to match things. So if we're talking about 10 out of 10 match, there's 1 out of 4 chance that a sibling will have 10 out of 10 chance, because there's 4 different combinations that it can end up being. But if we're talking about haplotransplant, meaning 5 out of 10 match, that increases to the chances of finding a sibling that is a match increases to 1 in 2, right? Because, for example, there's 2 siblings here who have red. So out of 4 siblings, 2 would be a match. So that's about 50% chance. So that already increases a chance to find someone a match quite significantly. And if we apply the same logic to a wider population in unrelated donors, that also expands our possibilities of who we can transplant. And that's especially useful for the populations that do have those quite unique sequences. Now, when we match someone, even though HLA antigens are the most important thing we look at, there are some other things we look at. So, for example, one of the important things is what we call CMV status. So CMV is a virus, it's called cytomegalovirus. About 50% of us have met this virus, probably had a little bit of fever, maybe didn't even have any symptoms whatsoever. And our immune system developed immunity and cleared the virus, and we don't even know that we had it. However, when someone is immunocompromised, meaning they had some issues with the immune system, or they had chemotherapy to prepare them for a transplant, or they have a leukemia, which is overwhelming their bone marrow anyway, and they don't have normal immune system, that means that virus, first of all, can reactivate, but that also means that we would like to match them. So, for example, the donor has CMV immunity and has seen CMV. If we transfer those cells to someone who never seen CMV virus, it can take over, and we might not be able to treat the virus because of how low the immune system is. But it's even more of a problem when the donor already had the virus, seen the virus. And if we're transplanting the cells which haven't seen the virus, we're wiping out the immune system to that virus. And again, it can take over the donor's immune system, and it can cause a really nasty, for example, bowel infection. It can also affect the eyes, so it can cause a lot of damage in immunocompromised hosts. Another thing that we look at is age. So we do know that the donors, so the recipients who received cells from the donors who were younger tend to do a little bit better. We're talking relatively small numbers here. So we're talking about 3% better overall survival for each 10 years the younger the donor is, right? So for example, 3% better overall survival in a donor who's 17 compared to a donor who donated cells when they were 27. So that's why in Anthony Nolan we do collect cells from people who are 16 and older. Usually they tend to be 17 and older, but we do accept 16 as well. And even though 3% doesn't seem a lot, you know, if you have a choice, and if you're in a privileged position where you have more than one donor, you would go with the best possible outcome to the recipient as you can. Now, when we look at our donors, when the transplant center chooses a donor, they also look at their gender. Because people with XX chromosomes and female donors, they tend to cause a little bit more GVHD than male donors. And sometimes that's something you want because you want that graft versus leukemia effect. But sometimes, for example, if you're transplanting someone who doesn't have cancer, you want as little GVHD as possible, and you would choose a male donor if you had a choice. Now, we do look at our donors' weight. This is a very practical thing. We tend to like our donors to be at least above 50 kilos, mainly because that means that they will probably be able to produce enough cells for any recipient. But because we do want to have a specific number, relatively specific number of cells that we're going to give, because we know the more stem cells we have, the better outcomes will be. So the minimum, absolute minimum we want to do is at least 2 millions per kilogram of the recipient's weight. But we do like to collect at least 5 million per kilogram per recipient's weight, just because we know that we might have some extra left that we can use later, or we're going to get better outcome with that. So the more the merrier. And because it depends on the weight, that's why we do want our donors ideally to be above 50 kilos. That's not always the case. For example, if you have a pediatric patient who's quite small, even the smaller donor would be able to collect enough cells. We do look at donors' blood group, but it's not a very important factor. We have tips and tricks of how to overcome it. It can be a problem for people who already start with not enough red cells. So for example, sickle cell patients, they already are sickling and they don't have enough red cells. And if you transplant someone with a big ABO blood group mismatch, that means that they will lyse a lot of their red cells, and that can cause sickle cell crisis. So in those cases, we really, really like to match the blood group, but it's not always the case. For example, in cancer patients, we do care a little bit less about it. Also, the method of donation. So we have two main methods, being bone marrow harvest and peripheral blood stem collection. And we do know that people who donate with the bone marrow, those cells cause less GVHD. but they do engraft slower. That means that those cells overtake the donors, the recipient's bone marrow a bit slower, which means that the recipient is at risk of infection or bleeding or not having enough red cells for longer. Whereas with peripheral blood stem cell collections, we do get more GVHD, but we do get quicker engraftment. And depending on who are we giving those cells to, that's what helps us to decide. General rule is that for malignant diseases, sort of cancer type diseases, we will give PBSC, and for pediatric population as well as non-malignant conditions, we tend to go for bone marrow harvest. But again, it's not a set rule, and it really depends on who we have in front of us as our recipient. Now, sorry, I should have pre-warned you. If anyone's squeamish about blood or anything like that, there's a little bit of blood here in these pictures, but it's nothing major. So hopefully I don't have any, awfully gore pictures or anything like that. But if you don't want to see any of those, for the next, I don't know, 30 seconds or so, I will be talking about this and we'll skip it, okay? So with a bone marrow harvest, it's only about 10 to 20% of our donations that we collect. As I said, it's preferred in non-malignant settings as well as in pediatric settings, but it is also done under general anesthetic. And that's something that's important for the donor because not everyone is willing to undergo that. That means that they're fully asleep for the procedure and they don't feel what's happening, but some people do not like to have general anesthetic. The way we do the procedure is the person is asleep. This is done in operating theatre. This is all as aseptic as possible, meaning that we are trying to prevent infection as much as possible. This is literally a needle into the bone. We take it from the pelvic bone, from the back, not the front, because there's not many important anatomical structures around that area. So we try to not to damage anything around there. We usually take between 60 milliliters to about probably 250, 400 max. So we don't take much at all usually. And this is the bone marrow harvest. They wake up and they might have back pain. That's why we ask our donors to take at least 2 weeks off work if they're going to donate in this way, because we want them to recover very well before they go to their work, especially if the work is a little bit more physical. We don't want to put too much strain on the pelvis to make sure that it's not going to end up being pelvic pain that lasts longer. Now, as I said, majority of our collections, however, are peripheral blood stem collections. And in the background, you can see a machine. So there's one needle in one arm and another needle in another arm. There's little tubes that go to the machine. Blood comes out of one of the arm. We spin it down, take out the stem cells, and put back in the rest of the blood. As I said, obviously, we can't completely pull out just the stem cells. There's a little bit of lymphocytes, 1 or 2 red cells there as well, because you can see the bag is a little bit red. But majority of the cells that we do collect are the stem cells, because that's the ones we're interested in. Now, in order for us to be able to do that, we need to give something called GCSF, which is a granulocyte stimulating factor, a colony stimulating factor. What it does, it encourages those stem cells to expand and to reproduce so that we can collect some of them. And the rest are left in the bone marrow. But GCSF stimulates some of those stem cells to come into the bloodstream so that we can then collect it with the machine. We usually give 4 days of GCSF, usually at 10 micrograms per kilogram. And that's relatively small doses compared to what other places do. If we don't collect enough cells on the first day, we might give them another day of injections and then collect a day after as well, so that we can get enough cells for the recipient to undergo a transplant. Now, I'm just going to shortly talk about some possible things where we might say to a donor that we can't accept their donation in a certain way, or that we and the things that can go wrong in those types of donations. Now, absolute vast majority of the donations will not have any problems to the donor, but there are some exceptions to that. So if someone is donating bone marrow harvest, they can, well, because they can undergo general anesthetic, and because we do try to get a donor to be as young as possible, they might never had any surgeries before, and they don't know how they will react to general anesthetic. So obviously there's always that small risk of that they might react to any of the medications used in general anesthetic. As I said, because it's taken from the pelvic bone, from the back, people can have a bit of back pain. Usually it settles within the first 2 weeks. For some people, it can take a little bit longer, and that's when we send them to have this private physiotherapy or address the reason why their pain is a little bit longer than that. In very rare circumstances, despite us trying to make it as clean as possible, we can introduce an infection. And also because we're going deep into the bone, we can cause some bruising around the site where we're going to go. The reason why we might say no to a donor to donate in bone marrow harvest way is sometimes it's the BMI, because the more tissues, and it doesn't have to be fat tissue, it can also be muscle tissue, but the more tissue you have, the more difficult it is to reach your bone with the needle. Because we do it blindly, we don't use any sort of ultrasound or CT scan. We go according to anatomical positions, and if you have a lot of tissue, it's easier to damage it, meaning that we might go into not the right place or something like that, or we might bruise you more, and that's not the risk we are willing to take for our donors. So that's why we have a BMI cutoff. Also, people who already have a chronic back pain, it can exacerbate that, because it's a very common side effect of bone marrow harvest to have a little bit of pain. But if you're starting with some pain already, that means that it can be even worse, and that might not be appropriate to do. And again, if we already know that you had a surgery and you had problems with general anesthetic, we will not allow you to donate through this method. With regards to peripheral blood stem cell collection, the majority of the discomfort comes from GCSF side effects. So a lot of people will have a little bit of bone pain, which usually they describe as having a little bit like flu-like symptoms, but relatively mild, and that sort of bone and muscle pain that people get when they do have a viral infection like that. But some people do get it a little bit more extreme, and sometimes they need something stronger than just paracetamol to manage it, something like codeine, for example. Again, it's very, very rare that the pain would be this intense, but it can happen. Especially younger donors can have a little bit of a GI upset, and that can range from just mild nausea to actually vomiting and having diarrhea. Headaches can also happen, especially if people already suffer from migraine, so it can cause a migraine. That's what we explore during the medical to see if they would be able to deal with the migraines, because one person's migraine is not the same as other person's migraine. And in extremely, extremely, extremely rare circumstances, which is less than 1 in 10,000, because GCSF also stimulates the spleen to enlarge, to become bigger, sometimes it can become so big that it can rupture, and that would be a surgical emergency, and the person would need to go to hospital. Touch wood, we haven't had any of those. And it tends to happen not for healthy donors, it tends to happen when we use GCSF in other medical contexts, like stimulating someone's immune system because they have neutropenic sepsis. But it's just something that we also mentioned to the donors when we consent them for the procedure. The apheresis procedure, the machine, when we take out someone's blood with that machine, we need to make sure it doesn't clot. And we use something called citrate to make sure that it doesn't clot. But what citrate also does, it binds to your calcium, and it can cause some significant shifts in how much calcium you have in the body. And sometimes during the procedure, we just need to give them some IV calcium or some calcium tablets. You can have bruising at the site where the needles are put into your arms, because they're relatively large needles. But again, people tend to cope quite well with that, and it's a very short-lasting thing. Now, the reason sometimes we don't allow people to donate in this method is sometimes if they have a very high BMI, that means that we won't be able to put the needles into the veins because we can't see their veins properly. So we would need to put in a central line. And that's sometimes not something we would suggest to our donors. And also we need to make sure that they don't have a condition that would become worse because of the GCSF, because GCSF stimulates immune system. So anything that is related to immune system can become worse. So for example, if someone has mild psoriasis, it's probably they're going to have a flare up. And if it's mild, that's not an issue. But if someone has psoriatic arthritis where it affects their joints, it can be an issue, and their joints might be painful, and they might need some medications. So that would be a bit too high risk for our donors, and we wouldn't be allowed them to donate. Okay. Once we do collect the cells, we nowadays we tend to freeze them, and the reason we tend to freeze them is because, well, mainly because of COVID-19 and all the problems it has caused, but also Brexit didn't help with getting the cells to the right countries easily. Extra paperwork being held up with at the airports and stuff like that. So we started freezing more cells, because what used to happen is that those cells, when they're collected, are infused within 2 days, so within 48 hours, 48 to 72 hours, and the recipient receives them 2 or 3 days later. But nowadays we tend to freeze them, so they have to be defrosted before we can put it into the recipient. There is some evidence saying that freezing the cells might delay engraftment, but the jury is still out on that. So we will see what the science say in the future. Now, talking about the recipient who is going to receive those cells that we collected, we're gonna talk about what diagnosis causes, what things people can be diagnosed with that would require transplant. Once the person is diagnosed, then they would receive a treatment for their condition. And we only transplant people for which the other alternative treatments don't work, or if we know that the risk of the disease coming back is very, very high. So we don't transplant anyone with a certain diagnosis, but they have to meet certain criteria. Because some of the treatments that the recipients are given, for example, if let's say it's a leukemia patient, blood cancer patient, they will receive chemotherapy, and some of the chemotherapy can be damaging to other organs, or maybe they already have underlying problems with other organs. So we need to make sure that when we will give them the transplant, and when we're going to give them the intense chemotherapy before the transplant, that we're not going to damage their organs to such a level that they're not going to survive. So we assess their heart function, we assess how well their lungs function. So we do a lot of assessments before we decide that that person is okay to go ahead with the transplant process. Transplant process itself takes at least 30 days, sometimes up to 3 to 4 months, depending on how many complications they have. And when they're undergoing transplants, that means they are isolated in a room where there's no other patients, because we know that the immune system is going to be so low that we are trying to limit how much of external, well, first of all, people, but also bacteria they're going to see, to make sure that we're not going to cause them infections when they don't have any immune system to fight against it. So that can be, as you can imagine, emotionally challenging when you're in confined to a room. It's not pleasant not everyone can deal with that very well psychologically, and that's why we have psychological support. Once the transplant is done and the cells have been grafted, so the meaning that donor cells now populating the recipient's bone marrow, it's not the end of the journey. We do follow them very closely, and we're going to talk about why. So most of our Anthony Nolan donors donate to cancer patients, and usually when we're talking about cancer patients, we're talking about leukemias. And we're talking about acute leukemias. So AML is more common in middle-aged to elderly people, and acute lymphocytic leukemia is more common in children. And we provide, our donors provide cells for both of these conditions quite a lot, because these are the most common indications. Sometimes some other blood cancers like lymphomas or more chronic leukemias, different types of leukemias, can also require transplant. But the acute leukemias are the bulk of the work. There are conditions that are not cancers as such, but still would require a bone marrow transplant. And that tends to be the cases for when our bone marrow, for one reason or another, is not able to produce enough of the cells for the blood, or they're producing cells that are not good enough to do the function that they need to do. And in this context, we're talking about bone marrow failure syndrome, such things as plastic anemia, Diamond-Blackfan anemia. The list is very, very long, but these are just a couple of common examples. Sometimes we are born with immune systems that are not working well. So, for example, severe combined immunodeficiency. An example is here. I don't know if you're probably not old enough to know this case at all, but this is a bubble boy. It's a child in America who had to live in a plastic bubble until the transplants were invented, because he didn't have any immune system whatsoever. That means any exposure to outside world can cause infection to him. So sometimes our immune system is not functioning to such a level that we would die of infection. And in those cases, we do transplant people. Another thing where we would transplant someone would be sickle cell disease or severe thalassemia, because that affects someone's life a lot. So people with sickle cell disease can have strokes at a very young age if they have a high-risk disease. And that means that we are trying to prevent something from happening by giving them a transplant to make sure the disease doesn't damage their organs too early, and give them a better quality of life where they don't need to come to hospital to have transfusions frequently. So these are just a couple of examples of the reasons why someone can be transplanted. Now, this is again just one of the multiple examples of what happens when we give a transplant and how does that journey look for the recipient. So day 0, in all of the protocols that we use for different chemo and radiotherapies to prepare the recipient for the bone marrow infusion, is the day of bone marrow infusion. Minus something day means that they're undergoing what we call conditioning, where we're giving them chemotherapy and radiotherapy. Not all regimens have both. Some of them have just one or the other. And then day +1 and so on are the days after the bone marrow infusion. As I said, this is just one example. This is actually a protocol for haplotransplantation, so 5/10 transplantation. And as you can see, this is a relatively short conditioning. So it's only 7 days of conditioning before we give the cells. Some of the protocols can be up to 21 days before they receive the cells. So they already spend that time in the hospital before they receive the cells. And then once they receive the cells, we are waiting for them to engraft, to take over the recipient's bone marrow. Once they do engraft, we can start seeing the GVHD as well. And for that reason, we give them medications to try to prevent the GVHD by dampening down their immune system. And those medications generally are called immunosuppression. Some of the examples could be mycophenolate mofetil here, or tacrolimus or sirolimus. You might have heard of these names in different transplantation contexts. They're used in renal transplants quite a lot as well. Now, we do need to talk about GVHD because that's the main complication of the transplantation of when we transplant allogeneic transplants, and that's where the matching comes into. So GVHD can affect between 1/3 to 1/2 of all transplanted patients, so that's quite a lot of people. Even though at most extreme cases, it can cause death in our recipients, but usually it just significantly affects the quality of life. It can be mild. It can be just a little bit of a rash on the skin that they just use a cream for. But in more extreme forms, it can be unfortunately life-changing. And GVHD is more common if you have a mismatch between HLA-A, B, or DR. So when we choose, our donors, we really want them to be matched in these. It's also more common in older recipients. So when we're transplanting a patient who is older, we expect to see a little bit more GVHD as well. When we condition someone for transplant, we can use very, 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 very strong chemotherapy. So we can use a bit what we call reduced intensity regimens. Now, reduced intensity regimens, a little bit of a euphemism, it's still very strong chemotherapy, but it's less strong than the other one. We talked about the PBSC donation. So when the cells are collected through apheresis, those cells are more likely to cause GVHD. GVHD can be acute or chronic. Acute GVHD just means that it probably happened between day plus 10 to day plus 100, although some places define it day plus 30. And the chronic GVHD just means that it developed a little bit later. Acute GVHD tends to affect three main systems. So your gut, causing diarrhea, vomiting, nausea, liver, your liver markers go up quite significantly. Your liver can't produce clotting factors. It can't process glucose as well. It can process medications as well. So you can go into liver failure at extreme, and it affects skin quite a lot as well. So basically, to be honest, it affects mainly the cells that have quite high turnover. The chronic GVHD can affect all these three systems, but it can also affect multiple other systems. So for example, eye GVHD can affect your eyes. And you can imagine if your eyes are always sore and you can't see properly, that would have such a significant impact on your life as well. Now, GVHD is not the only thing that we monitor when someone had a transplant and engrafted. So first of all, we need to make sure that we're not going to lose that precious graft that we transplanted from our donors into our recipients. And we check certain things on, we do a blood test to make sure the majority of the blood cells that we're detecting are coming from a stem cell that was in the donor and not the recipient, because we want the donor cells to be at least, well, usually about 99% of all the cells to be produced from our donor stem cell. Sometimes we do start seeing that the graft is what we call failing, and we start seeing that maybe only 75% of the cells are being produced by the donor stem cell. In that case, that's when we would ask for that top-up of the cells. We also need to make sure that if we transplanted someone for cancer, that cancer is not coming back. So some cancers do have genetic markers that we can monitor to make sure that they're not coming back. Because the moment we see the disease coming back, we need to do some other treatments. We also monitor them for GVHD, making sure that it's all okay. And we're monitoring them for infections, mainly because their immune system will go back to normal, usually after about 12 months. For the first 3 months, well, once the neutrophils recover, which is when they engraft, they will have some protection against outside world, but it's still not going to be as good as someone with completely competent immune system. So that's why we give them medications to prevent any sort of infection. So we give them acyclovir for viral infections, fluconazole for antifungal infections, for infections that would not be a problem for someone with normal immune system. And this is a very difficult process for a recipient, not only just the transplantation process when they're in hospital, but they might lose their income. It's a life-changing thing. And we do need to make sure that we look at them as a whole, as a person. So we provide psychological and social support as much as possible, although we could, because of the funding, it's not we would like to do a little bit better on those parts, but it's also something to discuss when we're following up our recipients. Does anyone have any sort of questions at all before we let Jerry to talk about her experience with Marrow, with being a volunteer for Marrow? Anyone at all? Well, if no one has any questions, I will let Jerry to take over and to talk about her experience. Thank you.
Thanks, Rita. So hi everyone, my name's Jerry. I'm a 5th year medical student now, so I'm in my last year. And just before I started, I was just wondering, out of everybody in this call, I was just wondering how many people are actually medical students and who's a non-medical student. So if you're a medical student, can you raise your hand or use the raise hand function, just so I know? So we've got one. I'm going to be talking about both things, but it looks like we might only have one for now. Anyone else? Okay, cool. So it looks like we've got one medical student and the rest are non-medical. That's fine because we're going to be talking about both. So if you don't mind changing the slide, Rita, please. Oh, sorry. Do you mind just, yeah, to the next one. Yeah. So yeah, that's great. So yeah, this is my Marrow journey. So I started Marrow like the week I started uni, because they were doing lots of socials and they were very welcoming and lovely. So I started volunteering with them as soon as I got there. So I've been volunteering for Marrow for the last 4 years. I was on committee in 2nd year as the volunteer coordinator, and then I was on committee last year as well as the president. And I'll be volunteering again this year, so 5 years of volunteering, which sounds like a lot, to be honest. But yeah, I've really enjoyed my time at Marrow. It's really honestly, it's been the best thing that I've done at uni, hands down. Like, it was the best thing to get involved with and such a good decision. These are just a few pictures of my time at Marrow. So the first one was at a freshers fair, which is usually starting about now. I think my Marrow group is actually at their freshers fair now, that's why they couldn't come to this, so they're doing that now. And then the second one was me at the national conference 3 years ago, so when we could do it face to face, and this was at the award ceremony, which was really nice, and they nominated me for volunteer of the year, so it was a really special evening for me. And then the other picture is from one of our fundraising events from the 10K, which I didn't actually run because I was not very good at running back then. So yeah, that's my Marrow journey. I've really enjoyed it, and it's been a really big part of my uni experience. But what I wanted to talk to you about today was to talk about how to use what you've done to benefit you, because you've done all this incredible work. Well, you will be doing it this year as well, and signing all these people up to the stem cell register, fundraising, doing incredible work. And I think that it should benefit you as well. So you should make the most of the stuff that you've done and be able to show it off for all the incredible work that you've done. So first I was going to talk about for the non-medical people out there, so it looks like the most of you this will apply to, so how you can use your experience with Marrow to sort of show yourself off and use your opportunities. So the first one I've got is it's great for a CV and an interview. So all the skills that you've gained over Marrow, you just need to sort of think back and pull out different things, and you can sort of like adapt it to make it sound like better for you in an interview. So you can say, if they ask you about team working, you can talk about team working. If they ask you about leadership, throughout your year of Marrow this year, you can nominate yourself for different team projects or something and have that in your sort of bank of stuff that you've done. So it can show, volunteering for Marrow can show commitment. If you do it for over a year, that's a long commitment. People will recognize that. 5 years for me, that's a long commitment. Hopefully people will recognize that. You can show leadership, organization skills, and team working. So lots of stuff that you can pick out there that employers want to see. And as I said as well, you can gain transferable skills. So you can talk about your team management. You can, even throughout this year, you can nominate yourself to organize a project. So like for Marrow last year, we did a recipe book. So you can sort of nominate yourself as a project manager, get yourself voted in if that's how your committee does it. And then you can put that on your CV, and that's a really good thing to do. Yeah, a volunteer job is a really great opportunity to just hone in your skills and show yourself off really and make yourself better at things, especially like IT skills. You guys will be learning how to use Canva a lot in the next year, so you can talk about how you learned a bit more about digital IT stuff and marketing. and definitely use those in a portfolio if you can. It'll also bring you job opportunities potentially. So after uni, if you're looking to go into the charity sector, showing that you volunteered throughout your time at uni will be such a good thing for your CV and be really, it'll really show you off. And yeah, especially if you're applying for a blood cancer charity or anything in the NHS, they'll definitely recognise Anthony Nolan as a big charity that they know. So yeah, really, really good to say that you've done that. Also, not many people know this, but at your university, you probably have awards for volunteering. So for my university, if you do like 100 hours of volunteering, which sounds like a lot, it's not a lot over the year, you'll just get it in easily. They do like a special gold award for volunteers. So that's a great thing to have as well. And you can do it for NCS and Duke of Edinburgh as well, if you need to fill those in. So a really good idea to do that. Have we got a question? Oh, I'm just going to carry on. Yeah, making the most of networking connections. So sometimes you meet random people at your Marrow events and you network. Just make sure you get their email, keep in touch with them, use the people that you meet. Like I've met people from like BBC Radio, and it's just really handy to just keep in touch with these people in case you want to use these connections in future. And then lastly as well, show off your talents. So you can use Marrow as a sort of excuse to build on your own talent. So you can do like a fundraising event for, say you're really good at like gaming, something like that. You can do a gaming fundraising event, or if you want to do like a drama play or something, use that as a fundraising event. Just you're doing a great job at volunteering for Marrow, but it can benefit you as well. That's basically what I'm trying to say. And then the next slide, if that's okay, please. So this is for, this was meant to say for, that was meant to say for medical Marrow opportunities, but yeah. So yeah, for medics out there, so medical students, this is really good for your portfolio and for your CV. So there'll be loads of chances to talk about team working and leadership and things. They always want to ask you how well you work as a team in medicine. So you can use these experiences to talk about if you have an interview or anything like that on your portfolio. Become your local heme hero. So for some reason in my uni, all the students think that if you're involved with Marrow, you're automatically an expert in haematology, which is kind of a big pressure to have on. But if you are really interested in haematology and you know a lot about it, then absolutely put on like little lectures for people, start small group teaching, and teaching can be really useful later on in your career to have in your portfolio to show that you've done teaching. If you are going to do it, get some feedback on it from the students that you teach as well, just to have in your sort of portfolio in the background, just so you can use it later on. It's really useful to have. Again, use your connection. So when you're out on placement, you might meet a haematologist or even an oncologist, and you can just name drop that you've volunteered for Marrow, Anthony Nolan, and most hospitals will have heard of Anthony Nolan, so they might get chatting to you. You might be able to organise an extra placement, show that you're keen, and it's a really good way of sort of getting really good experience. And then the last thing as well, you can try and get yourself published or win awards. So throughout medical school, they try and encourage you to get publishing points for the end of medical school, which can be quite difficult to do if your medical school don't organise it for you, which they didn't for me. So if you are thinking throughout medical school that you want to do that, you can just sort of like read different articles, interest articles, or think of your own project that you might want to do relating to stem cells, and write letters, or you can do letters to the editor or reply to things, or you can apply for awards and grants from like the British Haematological Society, and yeah, it's a really good thing to have, just in case you need it at some point. But yeah, so yeah, my final sort of tips, yeah, keep track of your achievements. Just get a document together or a folder or something on your email so that you can use it in future. Keep the details of your referees. So if you work with somebody for a long time and you think that they would be able to be a great referee for you, make sure you ask them, is it okay if I keep your details for a bit? Put yourself out there. Yeah, if you're gonna ask people to have like, you know, extra placements or help you with a project or something like that, just be brave and make the most of your opportunities, because if you don't ask, you don't get, really. That's the main point. And enjoy what you're doing. You're all doing incredible work, so you should be really proud of yourselves and want to show all this off. So yeah, and then lastly, I was just going to talk about what I've actually done in the last few months. So I've got builders, sorry. So I have been in London for the last 2 months on my elective here. So elective is a part of the medical course where you usually go abroad and practice medicine abroad for 2 months, but that was cancelled because of COVID this year, so we were told we had to stay in England. So I approached Anthony Nolan and asked them if I could join them this summer for some learning and a project if possible. So here I am. So I did a couple of weeks in the London Clinic, which is a collection centre for donors, and I met all the donors and I watched people donate, and I watched the donor medicals as well, as we've talked about, and I've also met a few patients, had some haematology and oncology exposure, and even watched a stem cell transplant as well. So I had the full picture, which was really, really useful. And then also, while I've been down here, I've been at Anthony Nolan in the offices behind the scenes, seeing all the different parts of the donor journey, which it's a lot of stages that they have to go through. So it was really interesting to learn all about that. I've had some great teaching from Ruta as well. And I've been set to a project which I should be completing soon, which is about COVID and how that's affected donation as well. So all really interesting stuff. And lastly, I was just going to say that if you are going to apply to do a medical elective at some point with Anthony Nolan, there's hematological grants available, not just from the British Haematological Society, but I'm sure there's others out there, or very generic ones as well. So that will always help you out with funding your elective. If you have any questions at all for me, I'm more than happy to be contacted, or any advice that you wanted, and that's my email there. But yeah, thank you very much for listening, and all the best this year with your new Marrow committees, and I hope it goes really well for you guys.
Yeah, so thank you very much, Jerry. That was very useful, and hopefully that gave you some ideas what else you can do with being a volunteer for Marrow, how that can benefit you as well, because your amazing work should be rewarded as well. And just to sort of say another big thank you for what you're going to be doing and enrolling all our donors. Well, not all, but a lot of our donors. So thank you very much. If you do think of any questions, feel free to email us. If you think that we should organize something else, again, feel free to email us and we can arrange something for you. Thank you very much for your attention. And I think we have a couple of comments here. So I think someone commented that we actually currently have 4 Marrow alumni working at the as part of Anthony Nolan team. So some people do actually even decide to have careers in Anthony Nolan. And then some general thank yous here. So thank you very much, and I hope you enjoyed the talk, and let us know how we can help you. Bye-bye.